Assalamu alaikum, everyone. We will be starting in just a minute. We're just admitting everyone.
Want to join? Mazen.
Yes.
All right, okay, we can start now. Assalamu alaikum, everyone. Thank you all for being here. This is Nada Bahzad. I am the Senior Program Development Officer at Qatar Reads. We have with us here Dr. Mazen Bashtawi. We're going to be discussing the topic of endometriosis and reproductive health. As an introduction, I'd like to introduce to you what Qatar Reads is, who we are, and our exciting programs. So if we can go to the next slide, please. Yep. Thank you very much. So Qatar Reads started off as a national campaign. We focused on raising awareness about reading, and then it slowly turned into the initiative and where we are today. We focus on raising awareness about reading in so many different ways. So we have 4 programs to do that. Our biggest program is the family reading program, where we have families that subscribe to us monthly and they receive monthly packages, really cute packages that encourage them to read. So they get 2 books, activity worksheets, comics, and it's a very exciting program to encourage the kids to read. And then at the end, they can create like a little home library for them. And the age groups we have from 3 years old until 13 years old. So if you're interested, you can visit our website to sign up. And then we've got Read to Lead, which focuses on university students, career professionals. We discuss a lot of important topics about leadership and different career fields. We also have our school membership program where we work very closely with schools, especially librarians, to encourage these school students to read and not to view it more as a chore or something just for learning, but they view it as an exciting, fun thing to do. And then finally, our exciting program, which we're here for today, is Mommy to Be, which is a 2-year program where pregnant women subscribe to us as soon as they know that they're pregnant. Or at any stage of their pregnancy, and we help them during this pregnancy, educating them through reading, through delivering very cute kits, as you see here today. We have our kit 1, our kit 2, they all have exciting things inside them. You can view our Instagram and website to know about what's more inside them. And part of our Mommy to Be program, we do such sessions and online sessions, or hopefully on site soon, inshallah, just like we're doing today, to inform our mothers on different topics. And today's topic is very, very important. If we go to the next slide. We have the Director of Women's Services at Al Ahli Hospital, Dr. Mazen Bashtawi. He's a consultant and a specialist in the mentioned fields. And today he will be discussing endometriosis and the reproductive health with us. Just a few house rules for this session. Dr. Mazen will be presenting. If you have any question, and we love to hear your questions, please do write them in the chat or have a note of them, and then we will allow you to unmute yourself if you want, or we will read the questions. So if you want to speak at the end, we're going to have a Q&A for 15-20 minutes. You can raise your hand. We'll select you to unmute and you can say your question to Dr. Mazen, and inshallah we'll be answering all your questions. Dr. Mazen, the mic is yours.
Thank you very much, Nada. I'd really like to thank Qataris for the great invitation. It's such an important topic, and I hope the audience would enjoy the presentation. So, endometriosis, a common yet an unknown disease. I see almost 1 to 2 patients every day diagnosed with endometriosis, yet when I say the word endometriosis, I feel like it's something that most women don't really understand, and I don't blame them. Hence, our session today, we want to raise awareness about endometriosis. I believe this is one of the most important topics we can talk about. So what is endometriosis? So excuse my drawings, but if you look here, you would see that this is the uterus. That's the neck of the uterus connected with the vagina. These are the ovaries on the left and the right, so as the fallopian tubes. The lining of the uterus, this layer, is a very specialized layer. It's called the endometrium. It's the inner part of the uterus. This area grows during the month under the effect of hormones from the ovary. And when the period time comes, this whole area will shed and it will come down as menses. So that's the normal thing. But endometriosis is defined as tissue lining the uterus. They started to grow outside the uterus, inside the tummy. It can be small patches, or it can be growing inside the ovary like a cyst. This might result to tissue sticking together, causing organ dysfunction. So every time women with endometriosis have a period outside, these small spots will grow and they will start to bleed inside. And it's known that bleeding inside can be irritant. So if on a scale of 1 to 10, most women would have a period pain of 2 out of 10, women with endometriosis might have a scale of 8, 9, and 10 out of 10. So very severe pain because of the internal bleed. I always tell my patients with endometriosis as if you're having a mini appendicitis every month. So that is endometriosis. If you look at this schematic diagram, you will see endometriosis can be inside the uterus, can be on the bowel, can be in the fallopian tube, can be even in the abdominal wall, especially after a cesarean section, or at the site of the cut down below after a normal delivery. And if we look at a laparoscopy, when we look inside, it will look like those small little patches. They're tiny, but they can cause an awful lot of symptoms. Again, same type. You look here, this is small endometriotic nodules that we can only see during a keyhole surgery. So, having put the diagnosis of endometriosis, why we're talking about it? Believe it or not, it affects 1 out of 10 women in our society have endometriosis. It's not a well understood disease. And if you have a mother, a sister, or a daughter diagnosed with endometriosis, your chances of developing the disease increases by 7-fold. 1 out of 3 women with endometriosis can have some difficulty in getting pregnant. Now, when we talk about endometriosis, we are not talking about one disease. And this is really the first most important message I would like all the audience to know and to convey to their friends and relatives and loved ones. So endometriosis is not a single disease. It's an individualized disease. Some of what I say might be applicable to you. Some of it might not be applicable at all to you. So when you go and you open the internet and you read in Google about things about endometriosis, it does not mean you're having those symptoms. The best person to give you advice is your doctor, who knows really well about it, who knows about your disease, who knows how to treat your condition. And as an example, I would like you to meet my friends, Elizabeth, Emma, and Elena. They don't know each other. The only thing that is common between those 3 women is that, yes, their name starts with the letter E, but they all have endometriosis presenting differently. I'm an optimistic person by nature, so I'll start with my first patient, Elena. Elena is a 42-year-old lady. She's a happy mother. She had a happy life. She had a successful career. She finished her family. She comes to my clinic asking for tubal ligation as she doesn't want to get pregnant. So when we put the keyhole surgery to do the tubal ligation, we look inside and we see a lot of endometriosis inside. And after surgery, we ask Elena, have you ever had any gynecological problem? She'll say, no. Do you have any difficulty in getting pregnant? She said, no, I have 3 babies, happy family. I never had any pain, yet she had endometriosis. So this is one variant of endometriosis. It's asymptomatic, it's a present, but it's asymptomatic. And that's why the amount of disease is not related to the symptoms. You might have only a small spot causing a lot of symptoms. You might have a lot of endometriosis, little endometriosis, and a lot of symptoms. So many women comes like Elena, and we hope all women with endometriosis will end up like Elena with no other health problem. But if we see Emma is a 25-year-old lady. She had her first period when she was 10, and everything was fine until the age of 15, where her periods started to be more painful, to the limit that she's taking the usual painkillers and it's not helping. She goes to emergency room. They will give her just the standard painkillers and they will send her home. Her parents are very worried about her because she's losing days at school because of the menses. Her colleagues are looking down at her saying, we all have that painful period. Why you're having this? It must be in your head. You must be imagining this type of pain. And sometimes relatives and loved ones will tell her the same. We all women, we all have these painful periods. And she started to accept the idea that all women having this type of pain. Emma finished her university. She goes to work. She again takes lots of days off work, and she cannot continue in one work. When Emma finally finds her better half and she gets married, they have a problem during the intercourse, during the intimate relations, because she might be having difficulty with the pain. Until then, Emma does not have a diagnosis. She has seen 5, 10, 15 doctors, and nobody has mentioned that to her. It's most of the studies suggesting that a delay in diagnosis of endometriosis can be between 5 and 7 years. So 5 and 7 years, Emma is having problems. She always go to the doctor or to the nearby family practice. They will give her painkillers, and that's all what they do. At one occasion, they might have done MRI scan or CT scan, and they can't see anything. They do blood tests for her, and again, they don't see anything wrong with her. Endometriosis is a different type of diseases. Sometimes it can be picked up by ultrasound. Many times you can't see anything on MRI scan or ultrasound scan. So until she went to see her gynecologist, who diagnosed her with endometriosis, her life was difficult. But now that she knows what's wrong with her, she can cope with it. She can ask for treatment. She knows what's going on. And believe it or not, this is a standard scenario. So many women, hundreds of women gets delayed in diagnosis because period, we look at period as something that women shouldn't be talking about. All women have pain and you should not ask for attention. So that's one of the classical scenarios of endometriosis. So these are some of the symptoms that might present. So this presentation of endometriosis, the whole presentation of endometriosis is pain. Let's see our last patient, Elizabeth. Elizabeth, again, she is a 28-year-old lady. She's been married for 1 year. She had occasional painful periods, but she's been married for 1 year and she was having difficulty in getting pregnant. So she went to see her gynecologist. They've done few tests. They listened to her complaint, did an ultrasound scan, and they could see a cyst in the ovary, which we call an endometrioma, and the doctor diagnosed her with endometriosis. So that's another representation, a difficulty in getting pregnant. Most of my patients, when they come to my clinic, they're telling me that we went to Google and it says that women with endometriosis are infertile, they can't have babies. And of course, that's not true. We know only a third of patients might have some difficulty, but 2/3 of patients will not have any difficulty in getting pregnant. So again, this is one of the faces of endometriosis. And we're talking about cysts of endometriosis. When your doctor does a scan in the clinic, he would be able to differentiate a normal cyst from an endometriotic cyst. If you look on this part, this is a normal ovary. It's an almond shape with a few follicles inside. If you look at this ovary, again, this is a topic which we can talk about later. This is a polycystic ovary, slightly enlarged ovary with a small little cyst. This has nothing at all to do with a cystic ovary. This has nothing to do with endometriosis. This is a different entity. We will talk about it later on. Some women come to my clinic saying, I have a polycystic ovary, and then I found that they have a cyst, and vice versa. So if you look at this final slide, you see that's the whole of the ovary, and there is a cyst inside. And if you can imagine that this cyst is lined by the same tissue of the uterus, every month there will be bleeding inside, and that blood will collect for some time, and it will change its color from a bright red into a brown. Hence, you might have heard about the name chocolate cyst, because it's an old blood collecting inside the ovary, and that's a chocolate cyst. Again, we will talk about the treatment later on. This is how an endometrioma will look on ultrasound scan. It's classical. Once your doctor does a scan, he will tell you, this is endometrioma, you have endometriosis, without having to do much more invasive testing. Sometimes if the endometriosis is only patchy in the tummy and the whole mark of presentation is pain, your doctor might advise you to go for a laparoscopy, which is a keyhole surgery to go inside the tummy and have a look at it. So, how do we treat endometriosis? Because endometriosis is not a single disease, your doctor will listen to you carefully, address your concerns. If your concerns are pain, then there is a different way of management. If your concern is inability to conceive, that's a different way of treatment. But generally speaking, we have a medical management and we have a surgical management. Let's focus a little bit on the medical management. When we talk about management of endometriosis, we have an awful lot of medications that we can use to treat endometriosis. The greatest struggle is to establish diagnosis, make the diagnosis, prioritize the symptoms. So if a patient comes to me with a moderate type of pain, we will start usually with simple painkillers and see how it goes. If the pain does not improve with those simple painkillers, we would escalate to use a little bit stronger painkillers. If this doesn't work, then we can use hormones. And if you can imagine that let's go to the first diagram. If you can imagine that the lining of the womb responds to hormones, if we manage to stop the period for some time, there will be no period inside. Again, we can do that using simple hormones like oral contraceptive pills can be a treatment. Either we use it on monthly basis or on tri-monthly basis. Sometimes we give hormones to make the endometriosis inside the tummy thinner, so the endometriosis will look thin, and a greater number of patients will respond to the medical management. If the medical management does not improve, or women continue to have symptoms, then we would go for surgery. If you look at this patient here, she had an endometrioma. You can see the chocolate material is coming out of it. When we're doing surgery, we always prefer to go for laparoscopic surgery. There is no point of making a cut in the patient's tummy just to have exposure. We stopped doing an open surgery for endometriosis for a very long time. I really feel very unhappy when I see women coming to my clinic when she had a surgery through a cut in her tummy. And because of endometriosis is a progressive disease, so we give medical treatment, we do surgery. Some of women eventually will come back again with the same symptoms even after surgery. There are few people who can do the full stripping and removal of the endometriosis. Because women keeps coming back with those symptoms, we can't just every time go and do surgery. It has to be a one surgery and a complete surgery. On average, women would have between 3 and 5 surgeries for endometriosis in her lifetime journey with endometriosis. So if you want to do surgery, you want to do one surgery, a complete surgery. However, doing a surgery for someone who has completed her family, we would go and excise all the endometriotic spots inside. So we can excise spots on the bowel, we can excise spots on the tummy, we can excise spots everywhere, especially on the ovary. However, for women who wanted to preserve fertility, it will be a different kind of surgery, because yes, we wanted to remove the endometriosis, we wanted to remove the endometrioma, but again, we wanted to keep the ovary safe with good reserve. There is no point of doing a surgery and making the ovary weaker and weaker. And that's the idea of not going on and doing surgeries on and on. Even if you have endometrioma, we know that the hormones that we give will not get rid of this endometrioma, the chocolate cyst, but at least it will make your symptoms better. If that endometrioma is getting bigger and bigger, a keyhole surgery can be done, and it will be done. Your doctor will know how to do it in a very special way, using special equipment to remove the endometriosis without affecting your fertility. So how we're going to treat our patient? Elena, we will do a keyhole surgery, we'll do tubal ligation, and we are not going to do anything for her. For Emma, it's going to be a lifelong journey. We wanted to see that first, the pain should be removed. We will give her medical management, and then we will wait and see what's going on. If she responds to medicine, that would be the best ever thing that can happen to her. She will continue on painkillers. She will use those painkillers only at the time of period. There are different types of pain that comes with endometriosis, and your doctor will be able to differentiate between a pain that only happens at the time of the period, which is a sign of early endometriosis, or a pain that is present at all time. So it starts around the time of the period, but with time, as the endometriosis progresses, those sometimes endometric spots will cause scarring around the nerves, causing some nerve irritation, and the pain can be a continuous on most of the days, in which case surgery would be an option. Again, there are different types of pain, so it's very important to know where the pain exactly, which area does it affect. So when we do our surgery, we look into the triggering point, we will try to excise the endometriosis that is apparent and the endometriosis that we can't see at the time of surgery. And what I mean by the endometriosis that I cannot see, there is an entity called deep infiltrating endometriosis, where it can be affecting the bowel or the bladder, and it's hidden. You can only see just the tip of it. This needs to be isolated, dissected, and removed for a better quality of life. So it's a fine balance between removal of the endometriosis and preserving the fertility. For Elizabeth, it's a much easier option. She needs to go to see a fertility specialist. There are different methods why women with endometriosis have difficulty in getting pregnant. Sometimes the endometriosis itself causes fibrosis and scarring, closing the fallopian tube, which is the one to transfer the egg from the ovary into the uterus. And sometimes it causes inflammation. That inflammation can affect the quality of the egg, and it can sometimes attack the sperms and prevent pregnancy. So your doctor will be able to identify the causes. He will be able to take you through a different kind of management depending on the status of the fallopian tubes. Some women can get pregnant with simple protocols. Some women might need to go for in vitro fertilizations, what we call a test tube baby. So to summarize, a medical management for endometriosis is an essential part, and it's the initial part. But laparoscopy, it's the gold standard thing where we diagnose endometriosis. As I said before, if it's patchy here and there, it might not be picked up by the MRI or ultrasound scan. Ultrasound scan can pick up cysts in the ovary. We put a small camera in the belly button where we can have a look inside. We see that this is the uterus, the fallopian tubes, and through small little hole. These holes are only 0.5 centimeter each. So we put small instruments and then we start and remove the endometriotic nodules. And surgery can be an easy one, but sometimes it can be a challenging one. If it involves the bladder, then a bowel doctor might need to be present at the time of surgery, a bladder doctor. If it involves the bowel, then a bowel doctor might need to be present. So most of centers nowadays, they have a multidisciplinary approach where a surgeon, a reproductive surgeon, a gynecologist, a urologist, and a specialist nurse for endometriosis, they work as a team and they plan the management of each single case differently. The surgery can be a big type grown-up surgery, or it can be a simple surgery depending on what we are trying to achieve. So there are a few take-home messages I'm really interested that the audience can take home from this brief presentation. Endometriosis is far more common than what you can expect. If we're talking about 1 in 10, and if we have 100 participants in this presentation, you would expect at least 10 of them would have endometriosis. It's not a well understood disease. We don't know how it starts. One of the theories talks about, when the woman menstruating, the blood will goes from down below, but sometimes it moves upward through the fallopian tube and goes inside. A live endometrial tissues can implant there and then. So this is one of the theories, but it does not explain all causes of endometriosis. Just for the completion of the topic, we see endometriosis, and very rarely in the belly button. Every month at the time of the period, they'll have a few spots of blood from the belly button. We see sometimes in the lung, where at the time of the period, they might have some coughing blood. Sometimes it's in the bladder, where just only at the time of the period, they will have red urine from blood. But these are very, very, very rare. It's an enigmatic disease. We don't know how it starts. We know how to treat some of its symptoms, but definitely until today, we don't know how to cure it. And that's why women with endometriosis will have a lifelong journey. We're hoping that by identifying it early, we can improve their quality of life, and that's the main issue of diagnosis. As I said before, a delay of 5 to 7 years, leaving women in pain is not a good thing. It's really affecting the life of a female, affecting her immediate family, kids, and parents. If we look at 1 out of 3 women with endometriosis can have some difficulty in getting pregnant. So women with non-endometriosis, they don't have to wait for 1 more year before knowing that they're having difficulty. They might go to see the doctor earlier, where this problem can be identified and treated. And the best advice I can tell you today is that endometriosis is an individualized disease. I see 100 patients, they all have endometriosis, but their treatment is completely different. Their presentation might be different. And that's why do not go and read and believe everything it said. It's really a multiple disease rather than a single disease. And I will leave a lot of time of the presentation for the questions, and I really look forward to answer your questions.
Amazing. Thank you very much, Dr. Mazen. Let's just get my video pinned. 1 second. All right. Okay. Amazing presentation. Thank you very much. I personally was very engaged. I'm sure everyone was too. I'm loving the number of attendees and I'm loving the number of questions that we're getting. It just shows you how much this is such an important topic. And we do have a lot of questions to clarify it. So we've got the first question from Amina. Amina says, 1 in 3 women have problems with fertility when diagnosed with endometriosis. Do chances of conceiving grow higher after the surgery, or is it the same?
It depends whether surgery is needed or not. Sometimes women with endometriosis have something called unexplained infertility. They don't have a cyst, their tubes are patent, hence they might not need surgery. It is known that surgery can improve the chances of getting pregnant. So if we do surgery and remove the endometriosis inside the tummy, the chances of spontaneous pregnancy definitely improves. It's different if a woman has an endometrioma, where surgery needs to be removed first, and then we would advise women with large endometrioma with a weak ovary, because if this blood has been collecting for some time, the ovary would be weak. So we advise her to go and see her fertility specialist, and then they will decide whether to give her simple hormones or they will go for an IVF. Eventually, most women with endometriosis would get there and would get pregnant. However, it's very important to ask for help early. You don't want to go and diagnose yourself with endometriosis when you are in your 40s and late 40s, when the chances of pregnancy is already low because of the age and not because of the endometriosis.
Amazing. Thank you very much. Madiha is asking us if we will be able to share the recording. Yes, we will. I would like to note that the whole session is being recorded and we're going to share it on YouTube, so you can forward it to everyone that would be interested and you can use it as a reference for the future, inshallah. Dr. Zahra Hayat is asking, having a first-degree relative with endometriosis increases risk 7-fold. How to prevent endometriosis in daughters if someone has endometriosis? So I would think, is it even genetic? That's part of it.
Yeah. Again, unfortunately, endometriosis is a not well understood disease. It's an enigmatic disease. We don't know how it starts. We don't know what are the factors that make endometriosis more. The idea of, and even the genetic, it's not well understood. It's not like if you're having it, your daughter will have it. It's all probability. And you might have endometriosis and none of your daughters will have endometriosis. But having endometriosis will raise awareness of earlier diagnosis. And that's one of the most key take-home messages from the presentation today. Do not wait. Do not leave your daughter in suffering, absence of school days, in agony at home, thinking that she's just only doesn't tolerate pain or have a low pain threshold. Get to your daughter, if she has any of these symptoms, get your daughter checked, make sure she doesn't have endometriosis. So the idea that it increases 7-fold is get to see your doctor, identify endometriosis early, get the treatment early, so hopefully the quality of life would be better.
Perfect. So just to build up on your answer, just to make it more clear for all the attendees, let's say there's a girl she just got her period, or she's been having her period and she's been suffering with a lot of pain. Is there any other indicating factors that would show the mothers that she should get checked? Because most mothers would say, she just has period pain, that's normal, just take any painkillers. So would you recommend, even if she just has strong pain, to go get it checked? Or are there any other symptoms that they should be aware of that could be contributing to this diagnosis?
It's an excellent question, because we don't know whether it's just only a pain or some other symptoms. As we said, endometriosis can affect the bowel, They might have pain at the time of opening her bowel. She might have pain at the time of urination. If she had a composite of those pain symptoms, sometimes women with endometriosis, they have a distended tummy because of the gases are building up inside the tummy at the time of the period. They feel that they're really bloated and they can't wear their own clothes. The only one who can differentiate between this is a standard normal painful periods and endometriosis is your doctor. The biggest part depends on listening to women symptoms and acknowledge their complaint and then do the investigations. One of the hallmark is if your daughter had her period by the age of 12 and she was fine, taking a few painkillers and she's all right, and suddenly every month you are taking her to the hospital to take more strong injections, that's one of the indications that she might have endometriosis. But we don't want to label women with endometriosis unnecessarily. I think if it reaches a stage where you have to go to the emergency room to get more medical advice, it's better to go to a gynecologist rather than general medicine to treat those type of pains.
Very interesting. Honestly, just hearing your answer, lots of people are coming to my mind, and I'm amazed that we're not actually aware about this case. A lot of people are going through this and they think it's normal. All right, let's move to the next question. We have a question from Ida. She says, are there natural ways to help with the pain caused by endometriosis each period besides getting an operation?
There are different ways of coping with the pain. The first part of coping with the pain is knowing that you have endometriosis. So you know now you have endometriosis and you have to deal with that and you have to build up your pain scores. The second thing is to get medicines. There are a lot of medicines available now in our pocket, which we can give to patients, from little small painkillers taking the time of the period to hormones. It's very important to choose the right medicine for the right patient. We do not want women and girls to suffer silently, trying to cope on their own without a help. Definitely they can go for yoga, they can go for homeopathic stuff, they can go for non-medical, they can go for exercise, they can go for improving quality of life, but they have to have that connection with their healthcare provider to take their hand step by step and gauging the treatment and matching it with the symptoms. We don't want to overtreat, and definitely we don't want to start doing surgeries for young girls unnecessarily. Sometimes the treatment of endometriosis can be simple things. It doesn't have to be strong hormones. It can be a simple painkiller as paracetamol. It can be a simple painkiller as one of the non-steroidal anti-inflammatory drugs. But as long as we are working on improving women and girls' quality of life, that's what matters.
Amazing. Amina's asking, and I think she's reaching the correct person. Is excision surgery for endometriosis performed anywhere in Qatar? I think you're the best person to answer this.
I think we have many centers in Qatar that can deal with endometriosis. And again, as I said, it's a multidisciplinary. There will be different kinds of surgeons. And I don't want to name hospitals, but I think the biggest hospitals in the country, they are more than equipped of dealing with this kind of surgery. The only thing that your doctor will have to go through the standard process of consenting and telling you about this excision type of surgery. Excision type of surgery can go from a half an hour surgery to 8-hour surgery. So we have to balance the benefits and the risks of the surgery. Yes, there are many centers in the country that they can offer this type of surgery.
All right. Now, just like Emma and all the cases that you mentioned, we have Mel here. She's explaining her case in detail. So let's try to follow. She's asking, with excision, which method do you use? She's had 5, I'm trying my best to pronounce the words, laparoscopies.
5 surgeries. Yes, that's the standard.
5 surgeries. She's now 31. She also has, oh my God, you have to help me, fibromyalgia, I think.
Fibromyalgia, yes.
Okay, that thing.
Yeah.
Interstitial, oh my God, I wish you can read this. Cystids, I'm not really sure. Amongst other things, she's also had her burnt off. She's not been to your hospital before, but the gyna she's seen here uh, they will not do another surgery. She has pain every day, especially around ovulation now. She's put Mirena coil in for now and also won't
Yeah.
do a hysterectomy. So she's
Yeah.
feeling quite lost and out of options. And she
Yes.
used almost everything out there for pain management and contraceptives wise. So if you
Yeah.
can help her with her case.
Yeah, it's an interesting case, and thank you very much. I did not want to go through that route and tell you about the different dimensions of endometriosis. Sometimes we see an endometriosis and we believe that this is the whole cause of pain, and then we're starting to focus all our efforts towards endometriosis. A chronic type of pain can be overlapping. One of them is called a premenstrual tension, where they would have some types of pain before the time of menses. As you mentioned, you have a fibromyalgia. Fibromyalgia is pain everywhere in the body. Again, that's in a participating part. You might have 3 or 4 diseases together, and it's very common to have those types of disease together. It's not a one-man job. It's not only treating the endometriosis. Having those types of pain can sometimes lead to an element of depression. So depression on top of, as a result of pain, can make things worse. So we need to deal with the fibromyalgia. We need to make sure there isn't any other pelvic nerve issues. We know that 30% who are presenting with pain, 30%, 1 out of 3, we cannot see anything at the time of surgery. It's just some sort of nerve irritation. And hence, types of sometimes pelvic nerve stimulations, other methods of treatment can add up. We don't want to keep going and doing surgery and surgery for endometriosis. You are 31, and I really feel it very difficult to go for a hysterectomy, which is removal of the uterus at such an early age. Your doctor would be able to advise you better. There are different types of medicines that we are currently having in the market. I was in the USA a couple of years ago, and there was a drug under production, which I think will be arriving to the Middle East market shortly. It's really an impressive medicine. I think it's going to have a major impact where we can use it for a very long time. The hallmark of endometriosis is that the ovary can itself stimulate those endometriosis. We sometimes use a diagnostic method. We give you this injection, and we see whether your quality of life will be improved or not. I don't want to tell you that hysterectomy sometimes can work, but many times it doesn't work. So I don't want you to go for unnecessary surgery and ending up having a lot of pain. And again, if we want to remove the uterus, do you remove the ovaries or not? It all depends upon your fertility wishes, whether you have completed your family or not. So removing the uterus can be as a last resort, only after you exclude other causes of pain, including endometriosis.
All right, thank you very much. I hope we helped you. Fritzy is asking, she had surgery for cyst removal back in 2014 and has been on the pills ever since. She stopped recently since her husband and her are trying to conceive. How does she know if she's ovulating again? And is there a possibility that her symptoms will be back now that she's off of the pills?
Endometriosis can be put to sleep using those pills, but we know it can come back again. One of its best treatment is getting pregnant, because pregnancy hormones can put the endometriosis to sleep. So women, after getting their first baby, their endometriosis might not come back after 5, 6, 7, 8 years at most. So that's one of the treatment, a temporary treatment of endometriosis. The way you know you are ovulating, some women would know at the time of ovulation that they feel some type of pain. It's called ovulation pain. Some women might not. If you're having your regular periods every 24, every 28, every 30 days, it doesn't have to be the same day, but it has a certain pattern. If you are having your period regularly as normal, you can predict your next period, that means you are ovulating. So that's not an issue. The only thing I am worried about is I want you to check your fallopian tubes. Do a test. Your doctor will be able to do a check to make sure that the fallopian tubes are patent and that you are ovulating. Again, for those busy couples where some of them are doing an odd shifts during the night shift, the easiest to do an ovulation test. It's a very simple kit. You go to the pharmacy, you buy this ovulation kit. At the time of ovulation, usually between day 12 and day 14, When you wake up in the morning, you do a urine test, you do the dipstick at home, and when it's positive, you know you're ovulating, you're going to ovulate in the night. So there are lots of things that you can do at home without having to go and see your doctor to know whether you are ovulating or not. And again, if you want to, you can go and see your doctor. They can look at the follicle, they can do the follicular monitoring as well.
Great, thank you. Chris Zani is asking, what is the difference between endometrial hyperplasia and endometriosis?
Okay, it's a completely different entity. I thought the question would be the difference between adenomyosis and endometriosis, and I will talk about endometrial hyperplasia. Endometrial hyperplasia is when the lining of the womb, the normal lining that is present inside the uterus, starts to behave in a bizarre way. It starts to grow out of order. There are different types of hyperplasias. Some of them, we might give them a simple pill and that would be it. Some of them, we have to put a Mirena coil, which is a hormonal coil, and that would be the end of it. Some of them, you might need to go to your specialist where a hysterectomy is indicated, what we call a simple hyperplasia or atypical hyperplasia. So there are different types of hyperplasias, but the hallmark of hyperplasia is an overgrowth of the lining of the womb inside the lining of the womb. The endometriosis, we talked about it. It's outside of the tummy. When the lining of the uterus started to grow inside the muscles of the uterus, that's so-called endometriosis interna, that's called adenomyosis. The hallmark of it is painful periods and prolonged bleedings. Instead of women having a period for 5 days, it lasts for 20 odd days. So that's called adenomyosis. It's some sort of abnormal lining of the uterus getting into the muscle of the uterus. That's the adenomyosis. Again, it's very common and it can be present with endometriosis.
Great. All right. Moving on to the next question. I'll keep it anonymous. I see some people sending the questions to me alone, so I won't mention the names. She would like to ask if the endometriosis in the endometrial wall of the cesarean incision can cause infertility nor cause of miscarriage, and also need for surgery to remove the lump, since other doctors do not recommend or require surgery.
Yeah. The endometriosis at the abdominal wall, again, we wanted to know whether this is implantation inside the tummy or implantation inside the wall. Implantation inside the wall, it's almost certainly after a cesarean section. The woman would have this kind of special tissue under the skin, in the wall, not inside the tummy, it's in the wall. Every month, they started to have terrible pain. These types of endometriosis, we are seeing it more frequently. And as a matter of fact, I have a case tomorrow to be done. They will grow. They will not go by themselves. They need to be excised and removed. Whether there is endometriosis inside, because this can be implanted at the time of cesarean section. And no matter how good a doctor is, it sometimes can happen. So we cannot blame anyone for why women having at the time of cesarean section. They might not have at all endometriosis. They have only that small nodule inside the tummy and it needs to be removed. It will not go by itself. If it's small, it can be managed expectantly, but if it's large, I would definitely advise for surgery. If it's associated with endometriosis inside the tummy, then that's a different story and that can affect the fertility. But if it's an isolated one on the outside, no, it does not affect fertility.
All right. Brittany is asking, can diet have a positive or negative impact on endosymptoms?
Sorry, can you repeat the question again?
Sure. Can diet have a positive or negative impact on endosymptoms?
The dye test that we do, if I understand the question right, the dye test that we do is we put a dye inside the uterus to spill outside to see whether the fallopian tubes are patent or not. We don't think dye test has anything to do with distribution of endometriosis.
I think she's referring to diet as in your food, the choices of food.
Oh, diet, not diet. Yes.
But a good answer. I think people needed to hear that. Dieting.
Oh,
yes.
It's a diet. Yeah, yeah. Diet, it's not really well known what kind of diet that can trigger endometriosis, what doesn't. There are lots of advice about to avoid different types of tryptophan components like chocolate, nuts, and certain types, but it has never been proven clinically because back to the basics, we don't know how it starts in the first place.
All right. We have also a long case here. I'll try to make it short. She's been diagnosed with endometriosis for the past 7 years, married for 8 and trying to conceive. She hasn't been blessed with a baby yet, but due to severe pain, she had 3 surgeries to remove cysts back in India, and one of her ovaries has been removed. Now, the doctors additionally diagnosed that her tubes are blocked, but very recently she tried with ICSI-EGG donor procedure and got pregnant.
Yeah.
But at the end of her first trimester, unfortunately, she lost both the babies. Does she have a chance of positivity or pregnancy?
When it's unfortunate that she lost her baby. The good thing is that she managed to get pregnant, and that's very important. So having to get pregnant once is a great indicator that she would be able to get pregnant again. She needs to keep trying. I know to go for the ICSI, which is the IVF test tube baby, is very expensive, and women will spend years and years trying to collect the amount of money to do the procedure. But it's really every penny you spend is worth it. It's better to do it when you are young and not to delay things until late. As you can see now with endometriosis, you have one surgery, then another surgery, then another surgery, and then you lost your ovary. We always trying to be proactive. We try to minimize the number of surgeries we do for endometriosis so we don't reach this stage where the ovary has to be removed and the fertility is compromised by surgery and by the disease itself. The advice is yes, endometriosis has an increased chance of miscarriage as well, in addition to difficulty in getting pregnant. But the only way to know is to keep going and keep trying. Remember, endometriosis is an individualized disease. What works for your friend and colleague might not work for you, and vice versa. What works for you might not work for your colleague. But you have to keep trying with the IVF now, since your fallopian tubes are blocked.
All right. Another question, another case actually. She was diagnosed with endo both right and left ovary. Right side is now 5 centimeters. She's 38, trying to conceive, and her gynae advised her to take pills, and instead she was given supplements for the ovary. Is there a possibility that the cyst will grow bigger?
There is always a chance that the cyst might grow bigger. Looking at this case, you are 38. The best advice is to go back to your doctor and you address your complaint as your pain or the cyst is a priority, or getting pregnant is a priority. If getting pregnant is not a priority for the time being, you want to delay it, that's a different story. The cyst, yes, it can grow. It definitely will not regress by using medicines. So either it will stay as it is, or it will grow bigger, or it will stay the same. We don't know. But a cyst of 5 centimeters, and you're 38, and you wanted to go for fertility treatment, my advice for you is to go straight away for in vitro fertilization, considering different things. The other thing is I am sure your doctor has already done a test to check your ovarian reserve, to check whether your ovary has been weakened by the endometriosis alone, because it's not only surgery that can weaken the ovary, the endometriosis itself can sometimes weaken the ovary. A full assessment of the case, and then your best shot is to go for the chances of success of IVF drops markedly after the age of 40. Still have a couple of years. And again, everyone is different. You might be different. You might have better follicles by the age of 40, but we're talking about, generally speaking, that you need to act today rather than wait until tomorrow.
All right. Another question, please, Dr. Mazen, help me with this word. She's asking, does a
hematosalpinx,
does it resolve it by itself?
A hematosalpinx is whenever you have endometriosis inside the fallopian tube, that can swell up the fallopian tube and will start to collect blood inside. And again, if you have this condition for some time, sometimes it's grow bigger, sometimes it just empties up. It depends whether the fallopian tube is opened from one side or not. Sometimes it's grow bigger, and under the effect of hormones, it will just deflate and it will empty. Sometimes it stay as it is. Again, it's individualized. Is your main symptoms getting pregnant, or is your main symptoms is pain? If your main symptoms is pain, then surgery definitely would help. If your main symptoms is getting pregnant, then the size of the fallopian tubes need to be assessed. If it's blocked and dilated, it needs to be blocked close to the uterus. So this blood and material does not go back to the uterus, affecting your pregnancy, causing a miscarriage. So it depends upon your symptoms. It depends are you aiming at, getting pregnant or pain.
All right. Another question, is there a chance that it will be cancerous in the future?
A very good question. We don't know the answer. Yes, we know that there are women with endometriosis inside the ovary. Any tissues can change into cancer, but having endometriosis definitely increase a little bit the chances of having a certain type of ovarian cancer from the endometriosis. The increase is a little bit, it is there, but I wouldn't start operating on every woman just because there is a small increase, small chance of getting cancer. So yes, it is there, but it needs to be followed up. And your doctor would be able to know if this endometrioma started to grow massively out of phase, then definitely surgery might be an option, at least to get a diagnosis before the spread.
Fair enough. All right. Is there any treatment beside hysterectomy for removing adenomyosis?
Adenomyosis is the endometriosis lining inside the wall of the uterus. It's one of the most difficult things to be treated by medicines. We do try our best to give medicines, give hormones. Sometimes I tell the patient that if it responds with hormones, I'll be very happy. But most of the time, it doesn't work. And hysterectomy is the ultimate treatment, but we don't rush it in the first place. It might be the only cure, but we try medical treatment before we go into the adenomyosis.
All right, last two questions because we're coming to an end. Can adenomyosis and it's a mouthful, and endo cause problems for C-section patients? If so, what issues may arise and what treatments are available? Is there anything the patient can do to prevent issues?
Issues at the cesarean section. Did I get your question right? Yeah. We usually, whenever I have endometriosis, sometimes tissues can't stick together. So that can be challenging to the surgeons. What we do at the time of surgery, whenever there is any adhesions inside or tissues sticking together, we try to release these adhesions. We try to, because we're doing cesarean sections, we are already opening the tummy. So we try to release all the adhesions as much as possible at the time of cesarean section, trying to put everything in order. It needs a special type of expertise where I think most doctors working in this specialty have to release those kinds of adhesions.
All right, I think this is the last question. Thank you very much, Dr. Mazen. I'm amazed and I'm so happy with the amount of questions. I'm very happy that so many women got to voice their cases to you, and I'm so happy that you had the time to help them. Thank you very much for being here with us. It's an absolute pleasure to have you part of Qatar Reads. I'd like to invite all the attendees to visit our website, qatarreads.qa. You can sign up to our Mommy to Be program. If you know any ladies that are pregnant, please invite them to sign up to our program. Thank you very much, and I wish you a lovely afternoon. Bye-bye.
Thank
Thank you very much. Have a great day. Bye-bye.